Hello. For those of you who have not met me yet, my name is Steve Edelman. I am the founder and director of Taking Control of Your Diabetes, as well as a physician specializing in diabetes care. I am also someone living with type 1 diabetes for 52 years, diagnosed as a teenager in 1970. I'd like to tell you a deeply personal and emotional story about myself, relating to my experiences dealing with the chronic complications of diabetes. Something, quite frankly, I have never done until today. I have overcome my hesitancy and embarrassment to speak about them, and I no longer feel that getting complications is a sign of failure or my fault. I no longer feel it labels me as a bad diabetic. I am hopeful that by telling you about my experiences, you can avoid diabetes complications completely or help you deal with them if you are already affected. As I mentioned, I was diagnosed at the age of 15 in 1970. I was put on one shot of insulin a day, measured the glucose in my urine, and was put on a strict diet using the old exchange system. There were no glucose monitors, no A1C test, no insulin pens, no pumps, no CGM devices, and no hybrid closed-loop systems. It really was the dark ages, and not too different than the treatment in the early 1920s when insulin was discovered. My sugar levels must have been all over the place, but I had no way of knowing. Despite doing everything I was told to do, my control must have been terrible as I was thirsty and urinating a lot, and that's just the way it was. These are signs that my glucose levels were out of control, as well as having severe hypoglycemic reactions that seemed to come out of nowhere. If they had the A1C test available, then I am sure I would have been above 9% for several years. But once again, I had no idea, as urine testing is just not that helpful. And one shot a day? Are you kidding me? There is no way in hell that could have kept me in a good glucose range most of the time. I was never educated in a way that I truly heard what was being said to me about the complications of diabetes and how to avoid them. I was too young, naive, and ignorant and thought that these things would never happen to me, no matter what. You know, my mother was a saint. She did the best she could to help me control my diabetes. However, my father, who was very mentally and physically abusive, did not believe I even had diabetes and refused to get involved or help me with my care in any way. You know, and looking back on those days, I think he was just ignorant and scared to death of diabetes. So he coped by ignoring and not acknowledging that I had it. It made my diagnosis and adolescence very painful in many ways. My story with diabetes complications starts with my eyes during my last year of medical school at UC Davis in Northern California. My good friend John, a big burly rugby player, gave me a huge bear hug, his way of showing affection. However, I quickly noticed blurry vision. The next day I went to a retina specialist who told me that I had leakage of fluid from the blood vessels in the back of my eyes causing my symptoms. He said very clear to me, I had the beginning of diabetic retinopathy or diabetic eye disease. Now, it was 1982 and I was 27 years old, only 12 years after my initial diagnosis of diabetes. No therapy was offered at that time, mainly because there were no proven ones. The treatment would have been quite different today, which I will get to in a few minutes. I did my medical residency at UCLA and then went on to the Joslin Clinic in Boston in 1986 for my specialty training in diabetes. And soon after I got there, I had a vitreous hemorrhage. One of those leaky blood vessels in my eye burst and filled my eye cavity with blood, and I was almost instantly blind in my left eye. Let me tell you that that experience was a wake-up call for sure. At first, it scared the hell out of me, and then I became pretty depressed, thinking about what was in my future. Would I lose my vision entirely? How would this affect my career in medicine and personal life? And since I am the glass half full type of person and always looking for a silver lining in things, I had this thought that having sex by Braille did not sound that bad. It does sound funny, but gotta laugh with the good and the bad. I saw one of the best retinal specialists in the United States, and he administered laser therapy to the back of my eye. Not the kind you get to avoid wearing glasses, but the type that cauterizes and stops the bleeding vessel or vessels. I had to sleep with a ton of pillows under my back, and eventually the blood settled, and I slowly got my vision back after several months. You know, and this is one complication that is with you every single minute of every waking hour during the day, because you had to look through blood through your vitreous. So over the next 5 years, while furthering my training at UCSD, I received a few thousand more laser treatments to both eyes to keep them stable and reduce any further bleeding. Now, this treatment did stop the bleeding, but at the expense of reduced peripheral and night vision. And I remember going to a movie theater with my girlfriend as we shuffled down the aisle, the row of seats, to find two open ones in the middle. I sat down on what I thought was an empty seat, and it turned out that I sat on a lady's lap who had a huge container of popcorn, which went everywhere. And so when you lose your night vision, it just takes you a long time to adapt when you go from a lighted area to a dark area. So now in 2022, let's talk about what's going on now. The treatments are incredible for diabetic retinopathy and another condition called diabetic macular edema, or DME. We have monoclonal antibodies. Now, you hear that word a lot. It's a wastebasket term for a certain way they make medications. You know, you've heard that for COVID, but they make these monoclonal antibodies that are extremely effective at slowing and halting diabetic retinopathy, sometimes completely. Now, these sight-saving medications have to be injected directly into the eyeball, and that's the vitreous of your eye. Now, it sounds like some type of torture, but in reality, it is relatively painless. You can follow me through an eye appointment where I actually get injected in my eye in our video vault off of our website. So what can you do to prevent diabetic eye disease or slow down its progression over time? So that includes all of you who don't have any eye disease now and those of you that do. So number one, glucose control over the long term is crucial. Diabetic retinopathy does not occur overnight or with one episode of high glucose levels. So don't panic if your blood sugars go up here and there. Keeping your blood pressure at goal is also extremely important. And three, regular screening. There are no symptoms of diabetic retinopathy in the early stages, so this is why yearly screening is so important. If diabetic eye disease in the early stages causes pain, we wouldn't have to screen. You develop eye pain, you go to the eye doctor, you would be treated very quickly, but it's asymptomatic, and you're going to see this theme throughout. So official screening starts 5 years after you have been diagnosed with type 1 diabetes. And for those of you with type 2 diabetes, it starts the year you were diagnosed. And the reason for this is because of individuals with type 2 diabetes may have been undiagnosed for years and years before the diabetes was discovered. So number 4 is make sure you see an eye doctor that specializes in the retina, who has lots of experience taking care of people with diabetes. I feel very confident in saying to you that if you see a diabetic eye specialist regularly, you have an extremely excellent chance of never going blind. It is the individuals who do not get regular eye care who have the serious eye problems. As for me, I had over 2,000 laser burns to each eye many years ago, and more recently, over the past 2 years, I had multiple injections of those monoclonal antibodies in both eyes, and I'm happy to report my vision has improved greatly and are quite stable. So remember, glucose control, blood pressure control, and regular eye screening by a retinologist. That's it right there. And oh yeah, avoid getting poked in the eye. And I'm serious when I say, if you're ever in a situation where you're working where something may shoot up in your eye, wear goggles. Okay, we got the eyes out of the way. Let's talk about diabetic kidney disease, also called diabetic nephropathy. So diabetic kidney disease usually appears in parallel with diabetic eye disease. They are both what we call microvascular complications. So as elevated glucose levels over the years leads to damage to the small vessels that feed blood to the eyes, kidney, and nerves. So that's basically the three classic microvascular complications. In addition to glucose control, elevated blood pressure over the years can also cause major damage to the kidneys. I will repeat this, but your blood pressure should be less than 135/85, with what we call millimeters of mercury. That's the units we use most of the time. But in reality, less than 120/80 is ideal, but it's possible to get too low, causing you to get dizzy when you stand up or bending over. So there is a sweet spot in there. The lower the better, but not too low. Remember that blood pressure jumps around more than airline tickets and hotel room prices. So that's why it's important to get a blood pressure cuff and measure frequent times throughout the day during certain periods over the month, not every single day. When I entered practice in Portland, Oregon in 1991, 21 years after my diagnosis, I had to submit a urine sample to get life insurance. At that time, I was married with one daughter, and I remember getting rejected because there was an excess amount of protein in my urine, one of the very first signs of diabetic kidney disease. You know what? This was another wake-up call for me. All of my other kidney tests were normal, and I had no symptoms. Once again, this is why screening is so important for diabetic kidney disease. You're going to get this theme throughout, that many of the complications of diabetes have no symptoms in the early stages, which is why you need to set up your own screening program. We'll talk about that. Currently, the screening tests are cheap and easy. The first is the EGFR, estimated glomerular filtration rate. This test tells you how well your kidneys are functioning, i.e. filtering the toxins out of your body. Normal is above 60. And you don't have to remember these numbers. You'll see them on your lab test for sure. This test is typically on most routine laboratory work that you get before seeing your healthcare professional. Now, the second important test is called UACR, urine albumin to creatinine ratio, which helps to define the structural damage of the kidney. One is functioning, one is structural. Normal is below 20. And your healthcare professional can plot your results over time, as it's important to follow these numbers longitudinally. Make sure you ask about these two numbers when you see your doctor. Let me just say that many doctors don't know about the urine albumin to creatinine ratio. So it just takes the results from your typical blood test, but you have to turn in your urine to measure the protein in your urine, which is the albumin. Let's review again, prevention and treatment strategies for diabetic kidney disease. I want to make sure you leave with some really important points. 1, make sure your blood pressure is at goal. Less than 135/85, less than 120/80 is even better if you're not getting hypotensive. Get a blood pressure cuff. Learn how to get accurate measurements and test at different times of the day. They make them for the wrist, the arm. You don't have to be testing a zillion times every day, but it's important to get tests when you wake up, at the end of the day, when you're sitting, sometimes when you're lying down. Write this down and give it to your caregiver. Number 2, if your blood pressure is not at goal, your healthcare professional will most likely prescribe a class of blood pressure pills called ACEs or ARBs, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, a lot of medical words here, but they are classes of blood pressure medications that have been proven to protect the diabetic kidney. So it's important for you to know that you may need more than one blood pressure medication to get to goal. Remember, it doesn't matter how many pills you're on, but what your blood pressure is. So that's important. Get your own blood pressure cuff, as I said earlier, and learn how to use it properly. So important. So 3, glucose control, and glucose control. You see that's a central theme throughout every complication. Get your A1C as close to 7% as possible. If your control is really not that ideal, and if you're on the conference today or looking at this video at some point, most likely you're going to be above 7%. Let's just say you're an 8 or 9%. Please don't panic, but just work slowly with your caregiver, your doctor, your nurse practitioner, your physician assistant to bring it down over time. It's not a sprint, it's a marathon. Number 4 is 2 relatively new medications have been proven to slow the progression of diabetic kidney disease. They are SGLT2 inhibitors, such as Farxiga and Jardiance, and also a relatively new medication called Kerendia, Kerendia. These medications have also proven to be very effective for people with chronic kidney disease and to slow down the progression over time. So our toolbox for diabetic kidney disease is getting larger. Ask your healthcare professional about these, and better yet, number 5, find a good kidney doctor or nephrologist that is knowledgeable about diabetic kidney disease. This is important if you have abnormal laboratory values, and probably not needed if your eGFR and urine albumin to creatinine ratio is normal. So, it really, you should use these specialists when you have issues. And number 6 goes without saying, avoid anything that would damage the kidneys, such as radiographic dye, like you get a CAT scan, they say with or without dye, and non-steroidal anti-inflammatory agents such as Motrin. So these are medications that can cause damage to the kidney, especially used over the long term in high doses. Whenever you start a new medication, no matter what it's for, you should ask your doctor if it has side effects that adversely affect the kidney. So back to my story. I do have diabetic kidney disease, stage 3A, which means I have about 50% of normal kidney function. However, I have been stable for about 10 years, and my eGFR is around 45 to 50, normal above 60. And my urine albumin to creatinine ratio, such an important number, is 345, normal less than 20, which is well above normal, obviously, but at least it has been stable. And it has gone down since I started the medication Farxiga, the SGLT2 inhibitor. I also take 2 blood pressure medications as well. And I obviously have a blood pressure cuff. So I do have an excellent nephrologist who specializes in diabetic kidney disease. And I am doing all the measures to avoid dialysis or the need for a kidney transplant. You know what? And if that time ever comes, I will learn how to deal with it as best I can. So the third classic microvascular complications is diabetic peripheral neuropathy. So we have the eyes, the kidneys, the nerves. We call it retinopathy, nephropathy, neuropathy. The triple opathies. We talk about that in clinic all the time. So diabetic peripheral neuropathy kind of runs its own course and does not go in parallel with eye or kidney disease. There are many causes of peripheral neuropathy. other than diabetes, such as certain vitamin deficiencies, exposure to toxins, receiving chemotherapy, and many, many more etiologies. So sometimes you might need a good neurologist to figure out where your neuropathy is coming from. Now, what helps us make the diagnosis is there are classic symptoms that first appear in both feet, not one foot, but both feet, including burning, tingling, sharp shooting pains, like being stabbed with pins and needles. And eventually, these symptoms subside over time, sometimes years, followed by numbness and complete lack of sensation. In other words, the signs and symptoms of diabetic peripheral neuropathy change over time. So prevention, once again, is dependent primarily on glucose control and avoiding nerve-damaging agents or toxins if you can. You need to have a level of awareness of these type of potential issues that may affect your nerves. In terms of therapies, there are too many to count, and they all work in many different ways. None are 100% effective, and it turns out that the best piece of advice is to find a podiatrist specializing in diabetic foot care or a neurologist who specializes in the area to methodically try the different treatment options depending on your symptoms. Many are listed in the TCOYD book, which is free to be downloaded. You can get that at our booth in the health fair. And the foot chapter is written by Dr. Ingrid Cruiser, who is extremely knowledgeable about diabetic peripheral neuropathy. So basically, if you have extreme pain, like sharp stabbing pains, it's one type of medication. If you have numbness and tingling, it might be a different. So it's really trial and error. And so it's really important that eventually you will find a treatment that will benefit you and your particular symptoms. Now, lastly, if you are truly numb in your feet, we call that insensate. Your doctor might do that 10-gram monofilament and you don't know where it is. You need to be super careful and inspect your feet every night to make sure you did not step on a tack and didn't know it and it was getting infected. For example, get good supportive shoes, and very importantly, do not wait 1 minute before seeking out a good podiatrist if you develop an ulcer or sore on your feet. If you scream bloody murder if you step on a little pebble or something sharp, then us as caregivers, we're not worried about you. That is a good thing. And your risk for developing a diabetic foot ulcer goes way down. So what about me? I do consider myself lucky in that I do have only partial lack of sensation and mild numbness, and occasionally I still will get those really sharp stabbing pains in my feet. And I might just yell, ow! And then my girlfriend says, what's wrong? And I just say nothing. And the good news is I don't need any medications, and the sharp stabbing pain only comes once in a great while. So I'm in that gray zone. So basically, it's important that you stay in touch with your symptoms and that you seek out help when you need it. Now, my good friend Craig Wargon, who's also a podiatrist, he bought me a pair of Hoka tennis shoes, which are really protective for using during exercise. So once again, be sweet, be kind to your feet. Autonomic neuropathy is different from diabetic peripheral neuropathy. Autonomic neuropathy occurs when there is damage to the nerves that manage everyday bodily functions, such as blood pressure, heart rate, sweating, bowel and bladder emptying, digestion, and sexual function. Wow, I hope that did not sound too scary. Symptoms of autonomic neuropathy really depend on what bodily function is affected and how severely, and typically in people with diabetes of long duration. With regards to digestion, the nerves that control the gastrointestinal tract from the esophagus all the way to the large bowel are not working properly. And one of the main problems that I see, and for me and many other folks, is gastroparesis. is a real pain. The peristaltic muscles of the stomach, controlled by the autonomic nervous system, are commonly affected. So when I eat, food stays there in my stomach way too long. I get full really fast and experience bloating and sometimes abdominal pain if I overeat. And it takes a long time for the food in the stomach to be propelled out of the stomach into the small intestine and down the rest of my GI tract. And let me tell you, that causes havoc with my glucose levels. And it is really hard to match the absorption of nutrients with the insulin I take. Okay, I may get hypoglycemic shortly after eating, which is unusual, like within an hour, because I've given myself insulin, but the nutrients have not been absorbed yet. And later on, the glucose levels go really, really high. Then getting off that roller coaster is difficult. Now, many folks living with diabetes for over 10 years may have a mild form of gastroparesis, so mild that they may not even be affected severely at all and not even know they have it. To make the diagnosis, it's usually made by your symptoms, and there's also a test called the gastric emptying study, which may or may not be helpful. Mainly, we make the diagnosis primarily by symptoms. So the basics of treating gastroparesis is not to stuff yourself at any one time, which can be tough. If you're starving, you need to eat slowly and try to avoid foods that take a long time to be digested, such as a tomahawk-sized steak for two that you order for yourself at Ruth Chris Steakhouse. And there are many therapies for diabetic gastroparesis, but it comes down once again to trial and error. They even have a gastric nerve stimulator that can help. And I'd say if you're having serious issues, once again, it pays to see a specialist, a gastroenterologist who has experience with diabetes. Now, my good friend from medical school, Dr. Jamie Wollison, is a knowledgeable gastroenterologist. He's given a lecture in our video vault and wrote the chapter on the GI manifestations of diabetes in the TCOYD book, once again, free to be downloaded from our booth. Well, I think that is enough complications for now. Remember to check out our video vault, our website, and the TCOYD book, 5th edition, for a lot more detailed information. When I wrote this lecture, getting ready for today, I said, wow, this is one complicated topic with a lot of information. And please write down your questions on our blog, and I will do my best to answer each and every one of them. In closing, since I started taking control of your diabetes in 1995, I have been speaking about the Diabetes Warranty Program. It is all about doing the tests and evaluations every year to help prevent or make an early diagnosis of one of the complications of diabetes. Early detection is the key to nipping these complications in the bud and preventing them from progressing to end-stage health problems. So the main message is that you can live a long and healthy life with diabetes. And remember, it's never too late to take control of your diabetes. All of you, I hope you stay well.